Good afternoon, student. Today's topic of discussion is amoebiasis, that is caused by Entamoeba histolytica. It is a parasite and it belongs to the protozoa group of parasites. Hence, it is a unicellular parasite. This amoebiasis, or caused by Entamoeba histolytica, it is found worldwide, especially in the tropical areas and developing countries. It is the third leading parasitic cause of death in developing countries. Important cause of diarrhea in normal patients as well as in immunocompressed patient in developing countries, like in AIDS patient. There is only human reservoirs is found. There is no animal reservoir, and mode of transmission is usually acquired through the contaminated drinks or water through the gastrointestinal route. And infective form of this parasite is cyst. Injection of the cyst specifically in the developed nation in UK and America. Now, habitat trophozoites, it inhabit the lumen of the gastrointestinal tract and also in the mucosa and submucosa of the large intestine. There are three stages in the life cycle: trophozoite, pre-cyst and cyst, but mainly remember it is trophozoite and cyst. It is the game of trophozoite and cyst. This is the trophozoite. If you examine under the light microscopes in high power, in normal saline mount, you will see there is a highly motile structure with endosome and nucleus, and it is usually motile with the help of pseudopodia. And this is the pre-cyst with it is you can find it in under the light microscope in the iodine mount. Although the iodine kills the trophozoite, so in iodine mount you will not get the trophozoite, but you will get the cyst form. And cyst form, pre-cyst form, it is with two nuclei, and it can also be stained by the special stain like Komori trichrome stain. And mature cyst contain 4 nuclei. It is also called the quadrinucleate cyst, and size of this cyst is 10 micrometer to 16 micrometer. It is small, spherical in shape. See, this is the picture of the immature cyst or pre-cyst containing less than 4 nuclei, usually 2 nuclei, and if the nuclei number increase progressively and the immature cyst become mature or mature quadrinucleate cyst. This is the picture of the quadrinucleate cyst. See, there are 4 nuclei, okay, and it is seen under the iodine mount, or also you can get in the saline mount, normal saline mount also, but you will get better picture under the in the iodine mount staining. Okay. And predisposing factors: intestinal motility, transit time, presence or absence of specific intestinal flora, diet of the host. All factors affect the colonization of this Entamoeba histolytica cyst. So if you discuss the life cycle, it starts from the cyst. It cyst from the feces of the infected patients. With the help of contaminated, this cyst contaminate the drinks and water, and when it is ingested by another patient or another person, the cyst enter into the gastrointestinal tract, and they can produce the mucosal ulceration, local mucosal ulceration in the large intestine, in the cecum and the colon. Then by hematogenous route, with the help of portal vein from this site, it enter into the liver, and they can of this amoebiasis. Now, clinical manifestation, it is manifested mainly in the normal person, non-immunocompromised patient, mainly acute or chronic watery diarrhea along with the mucus, may progress to the dysentery. So it starts from the diarrhea but it progresses to the dysentery. So what is the difference between diarrhea and dysentery? Dysentery is the diarrhea with mucus passage, but diarrhea is usually the passage of the loose stool, watery stool, and along with that abdominal discomfort, flatulence, tenesmus. Tenesmus means that defecation during pain during the defecation, and bloody or mucus containing diarrhea is common. That is see, this is the intestinal abscess or local ulcer that is seen in the interamoeba histolytica infection. This is the abscess. Okay. And what is the difference between amoebic and bacillary dysentery? Bacillary dysentery is caused by bacteria, mainly the Shigella, and amoebic dysentery is caused by this interamoeba histolytica. And onset of this amoebic dysentery is gradual, but in case of bacillary dysentery it is acute, and fever is usually present in bacillary dysentery, but it is usually absent in amoebic, or it is mild degree fever. And in feces examination you will get blood and mucus in amoebic dysentery, and in case of bacillary dysentery it is usually bloody and watery but without any mucus. Reaction is acidic in amoebic dysentery, but in bacillary dysentery you will get alkaline reaction. And in case of amoebic dysentery the color of the stool is dark red, but bacillary dysentery it is bright red due to the fresh bleeding. Amoebic dysentery, if you RBC, if it is examined, it is clumps, but it is in bacillary dysentery it is discrete in ruli, it forms the ruli, that is rulex or ruli, and pus cell is scanty in amoebic dysentery, but as it is a bacterial infection, bacillary dysentery, the stool contains numerous pus cell along with the macrophage cells. And ghost cell is also a specific form of this macrophage, so it is also found in the bacillary dysentery. Trophozoites of this interamoeba histolytica, it is seen in the amoebic dysentery but not in the bacillary dysentery. And charcoal lead crystal, it is very much specific for this amoebic dysentery. It is a special type of crystal that is seen in the amoebic dysentery but not found in the bacillary dysentery. Now, sample of choice is stool sample in diarrhea or amoebic dysentery patient, blood stain mucus, colonic scraping from the edge of the ulcerated areas by colonoscopic method, and stool should be examined macroscopically. You have to observe the stool, the consistency or amount of the stool. Is it mixed with the blood, fresh blood or not? It is mixed with the mucus or not? What is the color of the stool? What is the smell of the stool? It is acidic or alkaline in nature? Is it adhered to the container or not? These macroscopic gross examination reveals many information or give idea about collection. So that should be examined by the saline preparation. On one glass slide you have to put 1 drop of saline and you have to put 1 pinch of stool sample. You have to mix it with the wooden stick and you have to cover with a glass cover slip, and you have to examine under the high power microscopes, high power lens of the microscope. And if the trophozoite is present, it show the motility with the pseudopodia. And if you want to examine the cyst is present or not, you have to perform a iodine mount. It is same as that of the normal saline, but in place of normal saline you have to use 1 drop of iodine. Okay, because this iodine has some property. specific crystal. See, this is the picture of the charcoal-laden crystal that is found in amoebic dysentery. But remember, iodine preparation kill the trophozoite, so the trophozoite cannot be examined by the iodine preparation, and iodine preparation and saline mount both should be performed simultaneously in a same glass slide to identify both trophozoite and cyst. So this is the, and chronic amoebiasis carrier can be detected by detection of cyst in the feces by the same iodine mount examination. And if you in liver abscess, the surgeon usually drain the liver abscess and release collect some pus. That is typical description of this pus is anchovy sauce like pus because of its characteristics color and consistency, and it is called anchovy sauce pus in amoebic liver abscess. And last part of the aspirated material may contain trophozoite that can be examined by the direct microscopy or special smear like Gomori methanamine silver stain or periodic acidic skip stain. Hemotoxylin using stain can also be used. So treatment usually it is given by the metronidazole, it is the drug of choice. But to kill the cyst form, you can use the diloxanide 4-8 or hydroquinone. On tissue amoebocytes like dihydroamycin chloroquine can be used, but most important drug that is used for treatment of this amoebic dysentery, remember, this is the metronidazole. Along with for the killing of the cyst, luminal amoebocytes like diloxanide 4-8 or hydroquinone can be used. And supportive care with the normal saline, water rehydration and electrolyte replacement, sodium potassium balancing is also necessary as a supportive care. And control and prevention, obviously, as it is transmitted by fecal-oral route, you have to improve the basic personal hygiene and sanitation practice, and you have to manage the carriers. They have to diagnose properly and timely, as well as they should be treated properly with proper medication to reduce the source of infection. So this is a small discussion about the amoebiasis. Please remember, it is caused by Entamoeba histolytica, that is a parasite. It is a protozoa parasite, that is a unicellular parasite, and there are mainly two forms in life cycle, trophozoite and cyst. Cyst is the infective form and trophozoite is the disease causing form or pathogenic form, and both can be identified by the normal saline and iodine mount. Iodine mount is used for cyst identification, and the normal saline mount is used for the trophozoite identification. And the clinical feature, fever along with the amoebic dysentery. What is dysentery? What is diarrhea? You know, diarrhea is a loose stool, mainly watery, that is caused by usually